So first of all, welcome you all on behalf of Farmevo Private Limited. Myself Mahmood Zishan and I'm the Senior Product Manager in Farmevo. आज जो हमारा सेशन है वो हेड कर रहे हैं डॉक्टर मोहम्मद सिद्दीक अशरफ भट्ट साहब, who is the member of American College of Physician and American Association for Study of Liver Disease. So, sir, you can proceed now.
Thank you very much, Zishan sir. Today our presentation is on unmet need in the treatment of hypertension. It's not just to teach you something new, but just to memorize or sensitize all my colleagues about the new amendment and the new strategy for the treatment of hypertension. First, we see in the first slide that in the world, globally, 874 million people which are suffering from hypertension. And when we label a patient, he or she is having hypertensive or not, its criteria is that the systolic blood pressure is 140 mmHg or higher. 874 million people mean that the total world population at present is about 7,800 million people. And if we calculate the figure, it's account almost about the 10 to 11% of the world population is suffering from the hypertension. So it's very alarming situation that 11% of the world population which is suffering from hypertension. And as far as we are moving forward in the era of the fast food and the junk food and the high calories diet and low physical activity, these count increase and maybe up to double in 2050. In next slide, as we see that in 80% of the people in Pakistan are suffering from hypertension. With every third person above 40 years of age becoming increasingly vulnerable to a wide range of diseases, including MI, strokes, atrial fibrillation, heart failure, and renal failure. Clinically, if a patient presents to you which may or may not have any symptoms, but he or she is having hypertension, his systolic blood pressure is more than 140 and diastolic is more than 80, you must treat him or her for the hypertension. Most of the patients in our clinic say that we have not any symptoms, so we didn't need any treatment. But hypertension cause effect on their retina, hypertension cause effect on their heart, hypertension cause effect on their kidney. So these cause increasing the rate of MI, strokes, and atrial fibrillation, heart failure, renal failure ultimately. According to the WHO, there is 62% of the stroke and 49% of the heart attacks are caused by the high blood pressure. So high blood pressure may or may not cause symptoms in some patients, but you must treat it when you diagnose it. The risk of cardiovascular disease beginning at when the blood pressure reach at the range of 155 over 75 mmHg. And it's double with each increase in 20 over 10 mmHg of blood pressure. This slide is very important for the doctors because as a clinician, when we treat patient, the most of the patient did not show compliance for the treatment. These are the reasons why we're not able to achieve our blood pressure goals. And one of the most commonest reason, which is count for 77% in this slide, that patients are not compliant with the treatment. One patient is not compliant with the treatment, it is our failure. I think that we did not counsel him or her for the treatment of hypertension. We did not counsel him or her about the side effect, about the adverse effect, about the complication of hypertension. If we guide properly to patient what he or she have complication in the upcoming days or in upcoming life, then the patient may show compliant to the treatment. And the other risk factors, as we show, can see in the slide, the patient cannot tolerate side effect of associated with increasing dose. And the monotherapy is not effective enough. When we see a patient having not controlled blood pressure on monotherapy, then we switch it on to the combination therapy. And the other reasons are shown in the slide. Too many titration steps to find the right dose or treatment to reach the goal. Combination therapy is not started early enough. Most of the time, the patient presented to your clinic with a high blood pressure, which is almost 160 to 170 mmHg. That doesn't mean that every time when patient present to your clinic or in your OPD, you have to start from the monotherapy. If patient blood pressure is above 20 over 10, then your target, then you can start with the combination therapy at early stage. According to the AHA, the normal blood pressure is 120 over 80 mmHg. Most of the other guidelines like JNC8 and WHO, they are somehow lenient about the blood pressure target. But the AHA has very strict and tight control for the hypertension control. Because according to the AHA, the 120 over 120 to 129 is also included in the elevated category. And the stage 1 hypertension is 130 to 139 mmHg. Systolic or diastolic blood pressure is 80 to 89 mmHg. And the stage 2 is when blood pressure is over 140 over 90. But according to the JNC8, it said that the blood pressure up to 140 over 90 below the age of 60 is the target. But above the age of 60, they can tolerate the blood pressure target at 150 over 90 mmHg. So they are 10 mmHg is more lenient in the systolic blood pressure. This is the best slide, I think, in the whole of the presentation. As we read in our Quran, which is our ultimate target, that if the person can save the one human being, is as he saved the whole of the humanity. As we see in the slide, if we properly diagnose a patient and we just reduce the 2 mmHg of blood pressure of this person, so you can decrease the risk factor of stroke at 10% level. Similarly, if you decrease the patient blood pressure just in 2 mmHg less than the currently presented blood pressure, so you decrease the risk of ischemic heart disease almost 7%. So just decreasing in 2 point of blood pressure, mmHg of mercury, you can save so many lives from the stroke and from the ischemic heart diseases. Next, the best thing about, I always say that prevention is always better than cure. Whenever patient presented to our clinic, we always focus on the treatment, but doctors most of the time do not give time or do not have time to guide the patient according the diet plan for the relevant disease. In hypertensive patient, we must guide our patient to take the fresh vegetables, fruits, or healthy diets. And not just the diet, but keep the healthy lifestyle. Because the healthy lifestyle include all the things, include the healthy diet, include your physical activity, includes your sleep time, everything including in the healthy lifestyle. So one thing which is very important in the next slide, that in healthy diet, the most important thing is the salt restriction. Because the salt, most of the hypertensive patients are salt sensitive. Whenever they take the salt, it increase their blood pressure. So recommendation is to reduce the salt restriction, the sodium intake up to the less than 1500 milligram per day. Our teaspoon contain almost 24 milligram of sodium. So commonly we tell the patient that you decrease your sodium dose up to 1500 milligram. To simply say, you decrease your daily salt intake up to a half teaspoon or maybe less than it. So this is the recommendation for initial combination therapy, as I already said in the previous slide, that you can start the combination therapy whenever patient present to your clinic if he or she having their blood pressure 20/10 above their normal, our target range. But according to the JNC 8 guidelines, it has three strategies. The number one strategy is that you must have start one dose and titrate it to the maximum dose, then add a second drug. This is the strategy called strategy A, according to the JNC 8. But strategy B is you can start a single drug, then add on a second drug without achieving the maximum dose of the first drug. This is the strategy B. And the third strategy is you can start combination therapy just from the beginning. But when the patient blood pressure is 20/10 mmHg above their blood pressure target. So the best thing when patient blood pressure is above the 20/10 mmHg above their target, so we have to start the combination therapy at the time of diagnosis. We cannot wait until the patient gets the complication and then we start the combination therapy. So CCB or ARB combination synergy of counter regulation. CCB, we all know that CCB causes the atrial dilation and it causes ultimately the peripheral edema. But the ARB have the counter effect. ARB causes the venodilation and it attenuates the peripheral edema. So whenever you combine the CCB and ARB, the calcium channel blocker and angiotensin receptor blocker, so it counters the both effects. So it's best in controlling the blood pressure as well as the side effect of each other. So the combination therapy for the CCB ARB is the best therapy for the counter regulation. So telmisartan and amlodipine indications are, as we all know, in the hypertension, and the second one in the patient whose blood pressure is not adequately controlled on the monotherapy. These slides show that the telmisartan and amlodipine combination is the best for the 24-hour control of blood pressure as compared to the other ARB, which are losartan and valsartan. Telmisartan is the only ARB indicated for CV protection in CV high risk patient. All other are recommended for the control of hypertension, but telmisartan is the only sort which is recommended for the high risk patient, which are including the at the risk of coronary heart disease, the patient who is having the risk of peripheral arterial disease, and the patient having the risk of stroke. And the most important thing, the diabetic patient who are mostly the type 2 diabetic with the end organ or the target organ damage, the telmisartan combination with the amlodipine is the best for the control of these complications in this patient. This slide also shows that telmisartan plus amlodipine combination give the 24-hour control of blood pressure, both in the systolic and diastolic blood pressure. So this is the most important feature for the pharmacology of the telmisartan, because why telmisartan is controlling blood pressure up to 24 hours and controlling blood pressure more effectively than the other ARB. The reason is telmisartan have the best permeability and the highest tissue penetration because it is most lipophilic. It penetrates through the tissue and it's reached to the receptor site and it also has highest receptor affinity. So it causes the longest plasma half-life and the best control of blood pressure. It also have highest selective PPAR gamma receptor activation. So when it acts on the PPAR gamma receptor activation, because both alpha and gamma receptor, as we know, causes the best metabolism for the glucose metabolism and fatty acid metabolism. When it acts on the alpha or gamma activation, it leads to the fatty acid metabolism and also the glucose metabolism. And then we see in the next slide that it ultimately lead to the best control of diabetes. So telmisartan and glucose control, which I already said in the previous slide, whenever we give a combination of CCB or ARB, and this combination includes telmisartan, this is best for the patient who are having diabetes mellitus because it reduces the free plasma glucose level, and it also reduces the patient HbA1c level, because the pathophysiology behind all this thing, that it act on the PPAR alpha and gamma receptor, which causes the glucose, improve the glucose metabolism, which improve the fatty acid metabolism. So this is the whole summary about the telmisartan. One thing about the telmisartan, that it's having longer half-life, almost 24 hours. Second, it has better distribution throughout the body tissues, better penetration. It activates the PPAR gamma receptor, which causes best glucose metabolism, best fatty acid metabolism. So it also control the glucose level. It's best in the patient who is having hypertension with type 2 diabetes mellitus. So it causes low renal excretion because it excretes through the glucuronization, and after glucuronization, it's excreted in the human feces. So it having less renal excretion. Then no modification of the doses is needed. It also free from the drug interaction. Because it's excreted due to the glucuronization, it did not affect on the P450 enzyme. So P450, the enzyme interact with the other drugs, and most of the drugs which cause P450 inhibition or activation lead to the decreased quantity of drug, which ultimately lead to the decreased efficacy of drug. So this did not block or activate the P450 enzyme due to its metabolism from the glucuronization. Therefore, it is free from the drug interaction. And most of the time we have seen in our clinical practice that patient with the stroke or with the MI most of the time presented in the OPD or in the emergency department during the morning time, because all our body hormones surge come at the morning time, almost 3 to 4 a.m. In the emergencies, when we work in the emergencies, we have seen that most of the patient presented with the MI or in CVA at the morning time. So telmisartan have 24 hour have half-life. It's have better control over the control of blood pressure. So it control the early morning blood pressure surge effectively as compared to the other ARB. So the combination therapy in the telmisartan provided incremental blood pressure reduction in patient with uncontrolled on monotherapy. Second, it provides the significant blood pressure reduction in high-risk hypertensive patient. Third, it provides significant blood pressure reduction in patient who are having grade 3 hypertension as well as with type 2 diabetes mellitus. And it also lower the chance of edema as compared to the amlodipine because it counter the effect of amlodipine. So thank you for the presentation. If you have, you can ask.
Thank you very much, sir, for your valuable addition in the information about the hypertension. सर जिस तरह आपने अर्ली मॉर्निंग सर्च की बात की है, तो इनिशियली जब पेशेंट्स रिपोर्ट होते हैं किसी भी डॉक्टर के पास, तो किन पैरामीटर्स को मॉनिटर करना चाहिए कोई भी एंटी हाइपरटेंसिव ट्रीटमेंट ऑप्शंस उसको प्रिस्क्राइब करने के लिए?
सबसे पहले जो पेशेंट हमारे पास आता है तो उसकी एज बहुत इंपॉर्टेंट है उसको डायग्नोस करने के लिए। उसमें इस वजह से कि पेशेंट अगर आपके पास अर्ली स्टेज के ऊपर आ रहा है, यानी कि उसकी उम्र अगर 20 साल से कम है, तो फिर आपको उसको जो है वो सेकेंडरी कॉजेज ऑफ हाइपरटेंशन के लिए देखना चाहिए। अगर आपके पास पेशेंट जो 20 साल से ऊपर की एज का आ रहा है, तो वो जो एसेंशियल हाइपरटेंशन है मोस्ट लाइकली उसी में फॉल करता है। तो आपको सबसे पहले एज जो फैक्टर है वो बहुत अहम है। अब अगर आपने डायग्नोस कर लिया है कि पेशेंट जो है वो एसेंशियल हाइपरटेंशन का है, जो कि मोस्टली 25 से अबव एज के जो पेशेंट हैं, तो उनमें आपको पेशेंट को जो है उसमें आपने पेशेंट का जो एक तो स्ट्रिक्ट उसकी ब्लड प्रेशर मॉनिटरिंग वो आपने करनी है, और दूसरी जो चीज़ है कि पेशेंट के जो रिस्क फैक्टर हैं जो कि ब्लड प्रेशर को उसके बढ़ा सकते हैं, वो अपने साथ मॉनिटर करने हैं। उसमें उस पेशेंट का जो है वो उसका टोटल जो मेटाबॉलिक प्रोफाइल है वो उसको देखना है, पेशेंट का जो इलेक्ट्रोलाइट है, और इसके अलावा अगर आपको उसमें कुछ सेकेंडरी कॉज लग रही है तो साथ में आपने पेशेंट का हार्मोनल लेवल भी करवाना है। एक चीज जो सबसे अहम जो मैं यहाँ पे आपको बताना चाहूँ वो ये है कि मोस्टली जो पेशेंट हमारे पास क्लिनिक पे आता है चेकअप के लिए, हम जो क्लिनिक के ऊपर उसकी फर्स्ट रीडिंग लेते हैं, या जब वो सेकंड या थर्ड फॉलो पे आता है तो उसी को फॉलो किया जाता है। द बेस्ट स्ट्रेटजी इज द एम्बुलेटरी ब्लड प्रेशर मॉनिटरिंग। आप पेशेंट को कहें कि वो घर में अपना बीपी प्रेटस ले, और घर में जब वो रिलैक्स बैठा हो तब वो अपना ब्लड प्रेशर मॉनिटर करे। तो जब वो ब्लड प्रेशर अपनी मेडिसिन खा के उसको मॉनिटर करके उसका चार्ट बना के आपके पास आएगा, तो वो जो ब्लड प्रेशर होगा वो सबसे बेस्ट होगा, ना कि वो ब्लड प्रेशर जो कि आपके पास क्लिनिक पे आके चेक करता है। क्योंकि उसमें मोस्टली जो वाइट कोट हाइपरटेंशन जिसे हम बोलते हैं, जो कि डॉक्टर के पास प्रेजेंट करने में पेशेंट को आती है, तो उसमें वो भी रीडिंग शामिल होती है। तो कभी भी जो आपकी जो क्लिनिक रीडिंग है, जो ओपीडी रीडिंग है, उसको आपने कंसिडर नहीं करना। पेशेंट कहना कि एम्बुलेटरी ब्लड प्रेशर मीटिंग करे घर में, उसके अलावा उसको डाइटरी मॉडिफिकेशन बल्कि लाइफस्टाइल मॉडिफिकेशन जो वो आपने एडवाइस करनी है। और साथ में उसकी जो एड ऑन जो चीज़ें, उसका मेटाबॉलिक प्रोफाइल है, वो आपने लाजमी देखना है। पेशेंट की फैमिली हिस्ट्री, उसकी जो ईटिंग हैबिट है, ये सारी चीज़ें आपने देख के उसको फिर कंट्रोल करना है।
थैंक यू वेरी मच सर। ये सवाल वो सवाल होता है कि जिसके अंदर बाकी सारे जो भी मेजर और माइनर प्रोटोकॉल्स हैं वो सारे ही कवर हो जाते हैं, और अल्हम्दुलिल्लाह इसमें भी वो सारे ही ऑलमोस्ट कवर हो गए हैं। सो वी आर वेरी थैंकफुल टू यू फॉर योर प्रीशियस टाइम, कि आपने अपना टाइम दिया और हमें अपनी इंफॉर्मेशन शेयर की। इंशाल्लाह ताला वी विल कांटेक्ट यू, एंड इंशाल्लाह नेक्स्ट टाइम किसी और नए टॉपिक के साथ आपके साथ एक और सेशन हम लोग रखेंगे। थैंक यू वेरी मच।
जी, थैंक यू वेरी मच।